Picture this. What happens when your own immune system basically loses a tolerance to the intestinal microbiome and just starts attacking the digestive tract itself? Well, it's a pretty terrifying clinical reality. Patients are coming in with chronic, debilitating abdominal pain, unrelenting diarrhea, and severe nutritional deficiencies. We're talking about profound, repeating intestinal inflammation and the formation of incredibly destructive fistulas. The stakes here are absolutely high, and understanding the pathophysiology of this condition is literally vital for any modern medical practitioner.
So, welcome to this MedNexus Explainer. Today we're focusing our clinical lens on a condition that is honestly as complex as it is common: Crohn's disease. Whether you're an MBBS student, a NEET PG aspirant, or just a highly focused clinical learner, this explainer is built specifically to break down the realities of this disease for you. We're going to strip away all the confusion and build a rock-solid, highly visual understanding of exactly what happens when the gut is under attack. Here is our clinical game plan for today. We'll start with what Crohn's disease actually is, dive into the pathology and mechanisms, and then look at symptoms and clinical complications. After that, we'll cover diagnosis and compare it to colitis, go over treatment strategies, and wrap up with a high-yield exam review. All right, let's jump right into Section 1. What exactly is Crohn's disease? Let's define the condition.
So at its core, Crohn's disease is a chronic inflammatory bowel disease. But if you remember absolutely nothing else from this explainer, you've got to remember these two phrases: transmural and mouth to anus. Transmural means the inflammation doesn't just sit politely on the mucosal surface, right? It extends deeply through the entire thickness of the bowel wall. And unlike other forms of IBD, this abnormal immune activation, which, by the way, is often linked to the NOD2 gene and tends to peak in young adulthood, can strike literally anywhere along the gastrointestinal tract, from the mouth all the way down to the anus.
However, even though it can happen anywhere, it definitely plays favorites. The absolute most common site of involvement is the terminal ileum, the very end of the small intestine, right alongside the colon. Keep this specific location in the back of your mind, because it perfectly explains the classic clinical presentation we're going to see later on.
Moving right along to Section 2, Pathology and Disease Mechanisms. Let's look at the cellular and structural changes.
Let's actually look at the gross pathological findings. Because of that deep transmural inflammation we talked about, we see what are called skip lesions. Imagine patchy areas of diseased bowel separated by completely normal, totally healthy segments. It's like a damaged road with perfectly paved spots in between. Deep, linear ulcers and tissue edema intersect with each other, giving the intestinal lining this incredibly classic cobblestone appearance. You'll also notice something called creeping fat wrapping around the serosa, alongside deep fissures and strictures that form as these chronically inflamed walls scar up over time.
Now, if we zoom in under the microscope, the absolute classic histologic finding is non-caseating granulomas. Okay, test takers, listen up. This is a massive, high-yield detail for you. While these granulomas are considered a hallmark of Crohn's, actually, scratch that. You won't see them every time. They really only show up in about 30% of mucosal biopsies. Still, if a clinical vignette ever mentions non-caseating granulomas in a gut biopsy, your mind needs to immediately jump straight to Crohn's disease.
Which brings us to Section 3, Symptoms and Clinical Complications. How does this disease actually manifest in the patient? Patients usually present to us with chronic diarrhea, severe weight loss, fatigue, and these nagging low-grade fevers. Notice the focal point of their pain, though. It's almost always in the right lower quadrant. Why? Because the terminal ileum is the most frequently attacked site, making this frequently mimic appendicitis. Furthermore, that inflamed small bowel completely loses its absorptive capacity, which leads directly to things like vitamin B12 deficiencies and anemia. We also see a lot of aggressive perianal disease here, including really painful fistulas and abscesses.
But here's the wild part. Crohn's disease is far more than just a digestive disorder. It's a systemic, immune-mediated condition. The inflammation spreads way out beyond the gut. It attacks the joints, causing migratory arthritis and sacroiliitis. It pops up on the skin as erythema nodosum or pyoderma gangrenosum. It even inflames the eyes, causing uveitis, and messes with the hepatobiliary system, leading to fatty liver or gallstones. The entire body is truly involved here.
And because of that deep, transmural inflammation going all the way through the bowel wall, the major complications are structural and, frankly, severe. Chronic inflammation produces these tight fibrotic strictures, which can lead to really dangerous intestinal blockages. Then you have abnormal,
tunnel-like connections forming called fistulas that literally connect the bowel to the bladder, the skin, or the vagina. Long-standing Crohn's disease also significantly bumps up the risk of colorectal cancer. Recognizing these patterns early on is exactly how we prevent massive surgical emergencies.
All right, Section 4, Diagnosis and Colitis Comparison. How do we confidently identify the disease? So, what's in our diagnostic toolkit? We usually start simple with blood tests, looking for anemia and elevated inflammatory markers like CRP. There are also serologic markers like ASCA that can point us toward Crohn's. Stool tests help us rule out standard run-of-the-mill infections. But the absolute gold standard confirmation? That's a colonoscopy, which lets us visually identify those skip lesions and that cobblestone mucosa firsthand. CT or MRI enterography is also fantastic for revealing the deep structural issues like bowel wall thickening and those fistulas. And finally, a biopsy might just hand us that classic granulomatous inflammation.
Now let's put Crohn's disease head-to-head with ulcerative colitis. This is an absolute must-know differential for any medical board exam. Let's look at the location. Crohn's is mouth to anus. UC is strictly confined to the colon. For lesions, Crohn's features those patchy skip lesions. UC is continuous. As for inflammation, Crohn's is transmural, extending deep. UC is just superficial, mucosal only. Complications, Crohn's frequently forms fistulas, while UC is much more prone to toxic megacolon. And then there's the great paradox. Smoking severely worsens Crohn's disease, but is actually, weirdly enough, protective in ulcerative colitis. No way around it, you just gotta memorize that one.
Moving on to Section 5, Treatment and Management Strategies. Let's talk about the path to remission. We generally manage this using what we call a step-up approach. Think of it like climbing a ladder. For mild disease, we start on the bottom rung with corticosteroids like budesonide. If the patient is refractory to that, we step up to immunomodulators like azathioprine or methotrexate. Then we bring in the heavy hitters, biologic therapies. These are monoclonal antibodies like infliximab or adalimumab, which specifically target and neutralize inflammatory cytokines like TNF-alpha. It's a real game changer. We'll use antibiotics specifically to deal with abscesses or perianal fistulas. And surgery? That is strictly reserved for severe complications like obstructions or perforations.
Now, I need to pause here because this is a really critical clinical distinction. Unlike ulcerative colitis, surgery for Crohn's disease is never curative. Because Crohn's can affect literally any part of the gastrointestinal tract, simply cutting out the currently diseased section doesn't magically stop the underlying immune dysregulation. In fact, the disease very frequently just recurs right at the site of the surgical anastomosis.
But hey, medications aren't the whole story. Nutrition and lifestyle interventions are absolutely paramount here. Smoking cessation is absolutely critical. It is single-handedly the most important lifestyle intervention to prevent a relapse. And because of the severe malabsorption, patients usually require targeted nutritional supplementation, specifically getting vitamin B12 and iron replaced. We also push high-calorie diets during periods of remission, just to help them rebuild their strength. Let's bring it all home with Section 6, the High-Yield Exam Review. Here are your essential takeaways.
Let's lock in those absolute must-know, can't-miss points. Number 1, transmural inflammation is the hallmark. 2, patchy skip lesions are characteristic. 3, the terminal ileum is the most commonly affected site, usually presenting as right lower quadrant pain. 4, keep an eye out for non-caseating granulomas on histology. 5, smoking definitively worsens the disease. And 6, surgery is not curative. Catching this early and hitting it with targeted treatment is the only key to altering the disease course.
Which leaves us with a pretty fascinating clinical frontier to think about as we close out. Since Crohn's is ultimately an immune-mediated disease that affects multiple organ systems, how might future medical science shift from merely treating the inflammation locally in the gut to fundamentally reprogramming our entire cellular immune tolerance? It's an incredible question, and one that the next generation of physicians is going to have to solve. Thank you so much for joining me for this MedNexus Explainer. Keep learning, keep questioning, and I'll see you next time.